Good afternoon, everybody. My name is Kaylee Sada. I work for the American Heart Association as a program consultant in the heart valve disease space. I'm going to go through a quick housekeeping slide here. You'll notice that all of you are muted, and we do encourage you to use the Q&A panel to submit questions anytime during the presentation, and we'll address those questions at the end. Next slide.
Sorry.
Really quickly here, you can see that this is a continuing education activity. We can earn up to 1 CE credit, and you can see the different credentialing agencies there. Next slide. A quick disclaimer, and next. There are no disclosures. I'm going to do a brief introduction into what brought on this webinar series and the project we're working on, and then I'll introduce our speaker for today. In 2024, the American Heart Association received a grant from the Centers for Disease Control and Prevention for projects that will increase education and awareness of heart valve disease. The foundation of this grant was the CAROL Act, the Cardiovascular Advances in Research and Opportunities Legacy, which was signed into law in 2022. The association has invested in heart valve disease through multiple initiatives and has increasingly focused on opportunities further upstream of intervention. This grant in particular allows us to engage at the earliest opportunity for identification, the primary care setting. Through this work, we've collaborated with external organizations to broaden dissemination of initiative-developed resources, supported scalable efforts through 15 valve centers nationwide, working with referring providers, conducted landscape assessments to identify ongoing gaps in the patient care pathway, and developed new resources to expand our reach and impact across the valve patient ecosystem. As part of our healthcare professional education efforts, our cohort of valve centers has developed a comprehensive webinar series focused on key topics across the heart valve disease patient journey. Building on our initial webinar, our second session highlights core echocardiography concepts for primary care providers. And if you've not yet registered for our third webinar, our last in the series, please visit the website and registration links for future continuing education opportunities. That brings me to the introduction of our wonderful speaker today. David Skolnick, MD, a board-certified cardiologist, is the medical director of the Valve Center of Excellence at St. Luke's Mid-America Heart Institute and the director of the Echo Lab at the St. Luke's Health System. He attended University of Pennsylvania School of Medicine. His subsequent training was at Washington University in St. Louis, followed by a cardiology fellowship at Indiana University. Dr. Skolnick has twice received the Teacher of the Year Award from the Cardiology Fellows at the University of Missouri Kansas City School of Medicine. For 10 years, he served as a program director for the annual two-day Dr. Robert D. Kahn Heart Conference. In 2024, when he stepped down from that role, he received the Distinguished Service Award from his colleagues. In 2025, he was instrumental in creating the inaugural KC Valves Conference. The new educational initiative was designed to educate the cardiology community about important advances in the field of heart valve disease. Dr. Skolnick has been an integral part of the heart valve team at St. Luke's since 2010 and participated in many of the landmark clinical trials on transcatheter valve intervention. From there, I will let Dr. Skolnick take it away.
All right, thank you. Thank you. And thanks for inviting me to speak. We're going to try and cover this topic through the lens of echo and introduction to valvular heart disease. So we're going to start, before we get to this title here of the prevalence, I just want to review this picture from Frank Netter, a very famous medical illustrator who, sets the stage here for this topic, just to highlight the idea. Can you see my pointer? Does the pointer show, Kaylee? Oh, okay. So, huh?
I can see it, yes.
Okay, yeah, perfect. Okay, so we're going to talk about the aortic valve, mitral valve, and the tricuspid valve. And just to kind of remind you, when you have pathology with aortic and mitral and then LV dysfunction, almost always you'll have some issue about fluid pressure buildup back into the lungs. Patients will then become dyspneic, maybe not acutely, but over time, dyspnea, fatigue, As this process continues to get RV dysfunction, RV dilatation from pulmonary hypertension, and then ultimately, when it progresses, patients will develop edema. So you can see through this very simple mechanism of pathophysiology, a lot of what patients will have will be dyspnea, fatigue, tiredness, and edema. And these will be recurring themes that we'll talk about. But on to prevalence. David Cohen and his colleagues published this just last month, looking at the prevalence of moderate or greater valvular heart disease by age, and each bracket here is in 5-year intervals. And you can see that as the patients get older, the incidence of valvular heart disease is growing, which is part of this AHA initiative. And it's driven primarily by aortic stenosis, mitral regurgitation, and tricuspid regurgitation. We're not going to talk about aortic regurgitation for the most part because it's pretty small. Fast forward, you can imagine as the population ages, you can see where this prevalence is going to go for our next several decades. And these are patients that we've taken care of. You can see most of them are older patients, but I show the one on the right just to remind you that valvular heart disease can occur in the younger patient, not as commonly, but it's something to keep in mind as we go through these slides. I want to share this slide about the speed of science. A lot of it is about treatment and intervention, and this is not a talk about intervention, but as we have learned so much about catheter-based intervention, we have also learned a lot more about the natural history of valvular disease and how to take care of our patients better. So I'm going to start in 1970, which the first big advance was this a tissue valve, surgically implanted a bioprosthetic tissue valve, which was a big advance over the mechanical valves from the 1960s. And this is what we've had for a decade. It was open heart surgery, tissue valve for the aortic or mitral position, until Alain Cribier, a French surgeon in 2002, first in man did transcatheter aortic valve replacement, which really was the beginning in the early days of launching this whole field. We did our first one in 2008. The FDA goes on and approves a whole series of indications for transcatheter aortic valve replacement. Just to let you know, this was for the patients inoperable for surgery, and you could demonstrate an all-cause mortality reduction of 20% for those who were too sick to undergo surgery. This was for the high-risk surgical patient, the intermediate risk patients, and in 2019, the low-risk surgical patient, which really opened up this field for a huge number of patients. Shortly thereafter, we got involved, as the whole country did, in transcatheter intervention for edge-to-edge repair to fix mitral regurgitation. You can see the dates they were approved by the FDA, and transcatheter tricuspid valve intervention, whether it was replacement or a repair, approved in 2024. I showed this last one for early TAVR because this was not a new device. This was just perhaps a new concept or new idea that was tested, that should we fix patients with severe aortic stenosis earlier in their natural history? And this will be a recurring theme in the slides on aortic stenosis. I will remind you that the iPhone that we've all lived through came out in 2007. That was, the beginning of what we now take for granted, the smartphone. And I say that only because that's the year that JACC, the Journal of American Cardiology, the Journal of the American College of Cardiology, was still a monthly journal and frequently came in the mail. Today, the ACC is proud of a family of 10 journals. This just gives you an idea of the explosion of the science that we have learned. This is in cardiology. This talk is focused on valve disease, of course. And the pictures on the left are new transcatheter valve interventions or potentials in clinical trials. Some are already approved for the mitral on the left, tricuspid on the right. Again, we're not here to talk about intervention and therapies. I'm just saying that we have learned a lot through these clinical trials, and I'll share some of the highlights with you today. I do want to take a moment and just kind of give you the big picture understanding. This is going to talk a little bit about echo and show you about there's more to understand in the echo and the echo report than just the ejection fraction, though it's certainly a very important parameter. This is a patient with normal LV function. This is short axis view. We got this from a transesophageal echo. And you probably don't look at this day in, day out as I do, but I would like to share with you, this is a relatively small cavity, and these are thick walls with normal left ventricular function. Here's another patient, also has normal LV function. If you look at the two of them, one on the bottom has thinner walls and a bigger cavity. That's that black space in the middle. These are both patients with normal LV function and valve disease, and the ventricle has remodeled because of the nature of the valve disease. I don't want to take you back to medical school, but for just one slide, if I may, I want to show you this idea of pressure volume loops. So A is normal. This is a normal ventricular volume with a systolic blood pressure of only 120. That is normal. And you can imagine here, this is what it looks like for aortic stenosis, dealing with a very high blood pressure or systolic afterload. For mitral regurgitation, these ventricles are not subjected to high pressure, but the ventricles dilate from the volume overload of mitral regurgitation, just to give you a hint how the ventricle responds, and this will play out more as we look at other examples of ventricular modeling. We're not going to talk about E, which is aortic regurgitation. In the echo report, we of course try and simplify it for the clinician, for all of us, I would say. And the highlights are really, what is the ejection fraction, the status of the right ventricle, which is very important, and do they have valvular disease? And there was a new guideline recommendation from the American Society of Echo, came out last year, that says in addition to the impressions, what we should really be thinking about would be to include a comparison, particularly for valve disease. Is it stable? Is it getting worse? Also for ventricular function, is it improving or not? And equally importantly, the idea of recommendations. If there are recommendations to be made about what is the next step, and I'll show you what that looks like down the road, but this is what we've been doing for probably the last 6 or 7 years. We basically have copied the recommendations from the American College of Cardiology, the latest update in their guidelines, which is now 5 or 6 years old. The new ones are coming out, we're expecting in 2027. But it basically says here, in the absence of symptoms and normal LV function, the ACC/AHA recommends a repeat echo, and we give you some recommendations as to when they should be repeated. To be honest, we lifted this idea from radiology, who says if you have a nodule in your lung, please follow it till it clears. Could be cancer, could be pneumonia, but please follow it over time. It was that idea to say we should help the clinician. There's just too much information out there, and this is embedded in our reports. One last idea about ejection fraction. I just want you to think about when they say the EF is normal or preserved or lower limits of normal, I want you to keep in mind that that number should be matched with the disease that you're taking care of. And so for valve disease, for the asymptomatic patient, according to the guidelines, if you have aortic stenosis and it's severe and you have no symptoms, you may follow that patient down to an EF of 50%. For aortic regurgitation, it's down to 55%. And for primary MR, that's really a fancy word of saying prolapse. Anything under 60 is already too low. So keep in mind the ejection fraction you're following valvular disease, that it changes depending on pathology, just like LVH and dilated ventricles. And just to kind of drive home this point here one more time about ejection fraction, if you look at this picture on the bottom right, I hope you would come to the conclusion this is really, really poor systolic function, and that's a true statement, right? This is the same patient as in the upper left-hand corner here. This is actually during TAVR deployment. And when we deploy this particular valve, we try and create cardiac standstill so we can deploy a valve in the outflow tract. And we pace the heart at 180 beats a minute, cause transient hypertension down to a blood pressure of 40. You can see this LV function has almost no contractility. Deploy the valve, turn off pacing. So just to remind you that EF is a moment in time and very influenced by heart rate, blood pressure, preload, and afterload. I want another big picture, a slide I want to share with you about the words that we use as we grade valvular disease, because this is important for both us as we read echoes and for the consumers of our echo report. So it goes like this. This is severe aortic stenosis. This is the aorta, a heavily calcified valve with a lot of turbulence in the aorta from stenosis. We measure the peak velocity, Doppler data, the velocity and flow across the aortic valve. 1 is normal. This is anything more than 4 meters per second or mean gradient of 40 millimeters mercury is severe. This is well past 4 meters. So this is severe aortic stenosis, and this one is easy. The challenge is that we are confused by conflicting data, discordant data. And what I mean by that is that the valve area is small, suggesting severe, and yet the Doppler data do not support it. And so what do we call these things? This is not an easy problem to solve. And so this discordant data, sometimes it's labeled as moderate to severe. We straddle the fence. We're not sure. If we're not sure, you're not sure. And you'll see in a couple more slides, this may cause delay in treatment. This is severe mitral regurgitation. Mitral regurgitation comes in 2 sorts. This is ventricular mitral regurgitation, ventricular functional regurgitation, which means there's nothing wrong with the valve. The ventricle got too big. So there's nothing wrong with, let's say, shutters on your window. The frame got too big. It stretches open. The leaflets can't touch. This is a ventricular problem, and we call this functional severe mitral regurgitation. And in this entity, the moderate to severe, or some people call 3+ as opposed to 4+ for the severe, is a perfectly appropriate term. Not so for the aortic stenosis, but it is for the mitral, in part because the COAPT trial, which I'll explain to you, tested the idea, can we improve quality of life, heart failure hospitalization and death if we would offer edge-to-edge repair with a clip to reduce the leak for patients who have at least moderate to severe. So moderate to severe is the appropriate term as a minimum for the functional story. If we move on to tricuspid, this is a huge amount of tricuspid regurgitation zoomed up here. In the tricuspid space, in the early days, this may go back as far as 10 years ago, they realized that severe was not a big enough term to describe the degree of regurgitation that some of these patients have. And I'll show you some pictures. So they've come up with these new words called massive and torrential, not to be melodramatic, but this is to describe how severe these valves can leak. So for the tricuspid, just keep in mind, and I'll show this again, they are both preload and afterload sensitive. The ventricle, the right ventricle, depending upon the ventricle, will influence the amount of tricuspid regurgitation. Okay, two more big points I'd like to make on these valve lesions. Aortic stenosis is clearly a progressive disease. Over time, it will slowly get worse. For the heart failure patient with mitral regurgitation, we should really assess it after we've optimized guideline-directed medical therapy. It's a little bit cheating to have the patient in the hospital with decompensated heart failure and say, oh, look how bad that mitral regurgitation is. Yes, in the acute setting, but what we really want to know is what does that ventricle and what does that mitral regurgitation look like once they're optimized? It's really an outpatient management. Tricuspid regurgitation, as I alluded to here, is very preload and afterload. And the last point I want to make here is aortic valve replacement, whether it's with a catheter or with surgery, clearly reduces mortality. And our job in the clinic, part of what I'd like to emphasize in the next couple of slides, is trying to find those patients. Not so easy. Edge-to-edge repair will reduce heart failure hospitalization and death. Surgery for prolapse will normalize life expectancy. I'll show you data on that. And this is important to keep in mind, this last idea that we improve quality of life with catheter-based interventions for the tricuspid valve. It's not on the same level of mortality and hospitalization. Not that quality of life isn't important, but the urgency is a little less. Okay, so how do we make the diagnosis? You, me, in the office, how do we make the diagnosis of valvular heart disease? Well, we start with symptoms: dyspnea, fatigue, leg swelling, chest discomfort. Chest discomfort's not that common, and the first three are relatively vague. We listen. This is Norman Rockwell from 1929, and this is not to insult people who listen, but we do know that both cardiologists, primary care, it is hard to hear the murmur. In fact, the murmur is not always so audible, and then we turn to the echo to come up with our answers. But I've already alluded to the idea that sometimes we have some discordant data, and even echo, I shouldn't say that, but even echo has its limitations. And here are the limitations that accentuate this challenge. Patients don't always recognize or report their symptoms. Murmurs are not always detectable. I mean, I'll tell you, I do a lot of transesophageal echo studies on patients with valve disease. I know the answer for, I put the probe down often. I listen, sometimes I hear it, and sometimes I don't. It's not always so easy to hear the murmurs. And valve severity can be misclassified due to the complexity of the anatomy. And so sometimes we'll then turn to the patient. We'll ask some probing questions. And let me show you the limitations of the history. So this is a patient in our practice who has severe aortic stenosis, and the real question is, do you have symptoms or not? He was participating in our early TAVR trials, which means you had to prove you had no symptoms, you had to walk on the treadmill, but he was seen by the smart people in my clinic, the structural interventionalists, the cardiac surgeons interested in valvular heart disease. He's deemed and labeled as no symptoms, comes to the echo lab for a treadmill. There is panic, let me tell you, in the echo lab when this happens. This is how I find him. All his ST segments are down 3, 4, 5 millimeters. He has near syncope. He's diaphoretic, relatively hypertensive. There on the treadmill, I got down on the ground to chat with him, and I had one thought. I thought, please don't die. Please don't die. Well, his tachycardia resolved, so did mine. He got up, we parted ways, he got a new valve, and he's labeled as no symptoms. So what I now come to think about in this cartoon is, how's it going? So far, so good. Why do you ask? So I say this because for the disease that's going to reach an endpoint, for a disease like aortic stenosis, where you know it's clearly progressive, and you know that untreated, they're going to succumb from the valve disease, the patient has no symptoms, I would caution you to say we should not be lulled into the reassurance that they're safe. If they have no symptoms, I worry less about the patient. I worry more about the ventricle. They're going to die from ventricular pathology because of the valve disease. I worry about the ventricles. So prove that they are safe and safe enough to wait 6 to 12 months. Put them on the treadmill, particularly for the aortic stenosis. So segue into aortic stenosis. Far left, normal valve, it's smaller than a quarter. Bicuspid valves, remarkably common, 1 to 2% of the population, more common in men than women. There is what we call often a fused rami between two of these cusps. Rheumatic disease, we do not see that much in this country. These two lesions are typically in younger folks, and what we see here is the degenerative or calcific aortic stenosis of the elderly. And right out of the textbook, this is how we make the diagnosis of aortic stenosis. In the severe category, more than 4 meters per second of a jet across the aortic valve, a mean gradient more than 40, and a small valve area. And if we have time at the very end, I'll remind you about, or share with you what dimensional syntax is all about. It turns out, right out of the guidelines, this gets complicated. There are actually 3 subtypes of aortic stenosis that we should be aware of. There's the high gradient. This one's easy. I've told you these numbers time and time again, and this is the easy example, thumb on the garden hose, right? This one's easy. Often a murmur, easy to detect on echo. The next 2 get a little harder. So what this one says is it's a low gradient with reduced ejection fraction, and yet we're still going to label it as severe aortic stenosis. It looks like this. This is moving into this discordant data. You have a valve area that we say is small, and yet the supporting Doppler data don't say severe. If your EF is low, we give low dose dubinumine echo. And to ask the question, as we falsely increase contractility or augment contractility with pharmacology, can we prove that you can get a gradient or velocity more than 4 meters per second? And this is the cartoon that I would think about it. You look at the valve, you measure it, and you say, yes, it's really, really bad, but the flow's not so bad. So the dubinumine is as if you're taking your foot off the garden hose, you transfer increased flow. If you can prove it's high velocity, high gradient, you got severe aortic stenosis. And this is relatively easy to understand. This next one gets a little harder. The paradox about this, the paradoxical state, is that your EF is normal, and yet you still have a low flow state and a low gradient. I'll come back to this here in just 1 minute, but this is the example to think about. Just because your ejection fraction is normal does not mean that your stroke volume is normal. If your stroke volume is low based off an echo report, when your blood pressure is normal, you're in a low flow state. What causes low flow? What causes a low stroke volume? Well, in this example, profound LVH. Amyloid, which is perhaps as high as 25 or maybe 30% of these patients in this paradoxical AS that undergo TAVR, maybe it's amyloid, and we should look for amyloid. What also causes a low flow state? Atrial fibrillation, mitral regurgitation, tricuspid regurgitation. The heart squeezes. Most of it goes backwards. Very little goes forward. Other examples, and teasing all this thing out isn't always so easy. I want to share with you this idea of what Eugene Braunwald taught us in 1968 when he published really this landmark paper. And this has guided our understanding for decades until really in the last several years, we've had a real paradigm shift, which I'd like to share with you. But I think this is embedded in our understanding of valve disease. And what Braunwald taught us in his patient population, there's a relatively latent period when patients have severe aortic stenosis and no symptoms. And he taught us we wait for symptoms, the classic syncope, angina, heart failure being the worst. And without treatment, survival really drops. Now, no one's dying at 63 today from valve disease. Marty Leon updated this. I borrowed it from his presentation. People are living into their 80s. Truth be told, they're living into their 90s. And so we should redraw this. And what Marty Leon wants to share with us and taught us through a series of trials that he helped lead, this latency period isn't such a benign event, and we should at least recognize it. More importantly for this conversation, I'd like to share that the onset of symptoms isn't some point inflection that the astute clinician figures out or the patient can tell you. It is subtle, and it happens slowly over time, and this is really hard. And this is our challenge, and I'm going to spend a couple of slides emphasizing this because I think this is where we will serve our patients well, and I think marry well with what the American Heart Association is trying to do to recognize aortic stenosis early in the disease process. This is a cartoon that I share, and people actually remember this idea. So if it's all right, I'm going to share this slide with you. This is my humor. So severe aortic stenosis, I've told you, we know where this is headed. We know where these patients are going. And Braunwald would tell us, we wait for this inflection point. We have now science, in fact, early TAVR, this clinical trial suggests we should perhaps move a little upstream, because what happens is sometimes patients present halfway down the hill and they're quite sick. And last year at New York Valves at the big meeting, Philip Généreux came up with this idea, or presented this paper and this idea, which I think is super clever: acute valve syndrome. These are patients who are succumbing from valve disease, heart failure, and symptoms from the natural history. Remember, symptomatic severe aortic stenosis is a lethal disease. We're trying to get the timing right. Severe aortic stenosis is common. Of patients over 75 in this country, about 3.5% have severe AS. Of those patients, the majority have symptoms. Our job is to figure this out. Just one example, again, to share the limitations of the history. An 80-year-old woman reports dyspnea and exertion over the summer. Remember, this is a decade ago. We didn't understand this concept of early upfront intervention. A couple months later, she comes back from a trip. She's exhausted. Chief complaint, exhausted. All right, I'll let you decide what that really means. She struggles with stairs due to dyspnea, and it's attributed to obesity and arthritis. She gets an echo. There's no doubt she has severe aortic stenosis, both by mean gradient and a small valve area. And here's her EF, normal LV function. So the question isn't about diagnosis. The question is she ready for surgery? That's what we had back then. And our conclusion by a colleague of mine, astute, good clinician, says she's asymptomatic. Told her to call when she develops angina. Not unreasonable. 2 months later, dyspnea room to room. That's probably heart failure. 2 days later of heartburn. That's probably angina. Goes to the emergency department, and here's her ejection fraction. Today, we recognize this as acute valve syndrome, and she fell right off the cliff. And if you look back in the story, there were symptoms and signs that we just missed. She missed, we missed. Too sick for discharge. She spent 12 days in the hospital getting diuresis, getting optimized, and ultimately got TAVR and did well. Just to drive home the point one more time, these are the smart people a decade ago, but these themes have linger. So aortic valve hinges on symptoms. This is you and me in the clinic, right? In the setting of severe aortic stenosis and normal LV function. And here's what they say: interpreting the symptoms or the lack thereof is difficult. Classic symptoms are late. Who wants to be late? And yet early symptoms may be from aging. AS progression, this is troubling, variable and unpredictable. And by the time you get symptoms, you have maybe irreversible myocardial damage. And there's a wide variability as how much the ventricle tolerates the pressure overload of aortic stenosis. When I read this editorial, I snickered to myself. This is from 2012. I thought, oh, look at that. They got it wrong. Systemic disease. No, I got it wrong. It's a systemic disease. It's not a valve disease. This is what the authors wanted to teach us. Hypertension adds to the ventricular afterload. The ventricle doesn't know what the problem is, whether it's aortic stenosis and or hypertension. The ventricle just knows it's struggling. And coronary disease adds to the ventricular disease. You get fibrosis, remodeling, infarction. And now our patients are older. They have this whole litany of comorbid conditions that either cause symptoms or affect the ventricle. This is not what Eugene Brunwald had. In the 60s, his patients were probably relatively healthy and young. I want to share this slide of cardiac damage. I think this really helps summarize this idea of ventricular pathology or cardiac pathology, and helps you look at the echo report, not just the ejection fraction and not just the severity of a valve disease, but get a more holistic view of this. This is a clinical trial partner too. We participated in this. Intermediate risk patients for surgery. Everybody got a valve, whether it was surgical or TAVR, and the mortality at the end of the 1 year was the same. And they looked at these patients and divided them up in different stages of damage. Stage 1, all you had was severe aortic stenosis. Everything else was good. Stage 1, you have problems with the ventricle, hypertrophy, diastolic dysfunction, maybe some LV dysfunction. Stage 2, you're into the left atrium, mitral regurgitation, atrial fibrillation. By stage 3, you're onto the right side. Bad news. Pulmonary hypertension, tricuspid regurgitation, and by stage 4, you have significant RV dysfunction. 1 year mortality, no surprise. Not just as bad as your ventricle gets, but the worse your whole heart gets. This isn't just from aortic stenosis. This is the intersection, the confluence of all the disease states that our patients have. So I ask you to kind of look at the large picture when you look at echo reports. A lot of valve disease. Look at that. A third had mitral regurgitation. A quarter had tricuspid. 85% of patients were in this category. So some common themes over the years. We should think about treating early or earlier. Don't forget about guideline-directed medical therapy. Important for these patients, certainly after their valve is fixed, we're just on the next journey. We haven't necessarily cured them. And this, I like this quote a lot. I'll read it. The growing burden of evidence all seems to point to the same direction. The need to consider valvular disease as a cardiac disease, not a singular event. This brings me now to the initiative that the AHA has been supporting and investigating, Target AS. Brian Lindman presented this last month at New York Valves and published last month. This is an initiative by the American Heart Association to try and understand what the current state is and how we can improve the care for patients with aortic stenosis. I'm going to just show you a snippet of the paper. They defined early diagnosis as an abnormal echo, an echo showing severe aortic stenosis, coupled with a visit in the clinic within 30 days to figure out who has symptoms and who hasn't symptoms. So severe AS, early visit, make the assessment. Now you could say we're making progress between 23 and 24. You could also say we have plenty of opportunities to improve. And what they found are themes that have been published in the past. This issue of discordant data is problematic, particularly when we in the world of echo do not necessarily nudge the clinicians as to what the next step might be in clarifying that. Lack of clinical recommendations. Lack of timely follow-up, again, maybe recommending when the next echo should be so their patients aren't lost. And finally, in the conclusion, they talked about is we know that we need a multidisciplinary team with coordinated systems that includes primary care, general cardiologists who are seeing the same patients, and then, of course, echo, interventional cardiologists, surgeons, and the list goes on. This is really a team approach to recognize early recognition and to follow these patients. This is an opinion paper that came out earlier this year, basically encapsulating everything I just talked about. The idea that we should refer early when there is severe aortic stenosis is suspected, agnostic, regardless of symptoms. They then have a multidisciplinary team approach. They're going to streamline the evaluation. Maybe there will be a need for other diagnostic testing. I don't want to get lost in that detail. Worry about aortic stenosis, send it down the road. If they have symptoms, we should treat them early. And if they're not symptomatic, we should follow them very closely because we know where they're going to head. This is just a little fun. I just wanted to share with you. This was a lecture that Brian Friedman gave in honor of Eugene Brunwald at ACC a couple months ago. Can you detect aortic stenosis with an ECG? The idea, can you democratize the surveillance of this assessment? I've shown you patients may not report their symptoms. We may not hear the murmurs. Echoes are expensive and aren't easily obtained. Echo also has some of the limitations. I'm not here to kind of say the echo isn't the gold standard and the cornerstone of imaging. I'm just saying that we have our limitations occasionally and it's not so easy available. Yes, this is easy. This is not so hard. And they've demonstrated, and this is proven, it's not commercially available yet. But the idea is that you teach a computer with artificial intelligence and large language network learning modules, and you can teach a computer to recognize aortic stenosis based on EKG and abnormal echo. Relatively easy. What he showed, which was really interesting, is can you detect it with your voice? Think about what this would bring to our patients. So this is how the idea works. Here's the vagus nerve that gives off the recurrent laryngeal nerve that wraps around the aortic arch. If you have severe aortic stenosis, you can imagine there might be some changes in the vibration in the aorta that might be detected on this nerve. With a voice recording, there's your larynx, there's a voice recording, you feed it into your smartphone, goes through this algorithm, and the area under the curve is tremendous with a negative predictive value of 97%. This might be the future of how we capture valve disease. All right. We're going to move on from aortic to mitral, which has really now become my favorite valve to think about. So conceptually, we sometimes think of the mitral valve as like shutters on a window, open and close. But it turns out it's a whole lot more complicated. It's this complex three-dimensional structure. It's described as a saddle shape. This is what it looks like with a surgeon's view. This is a pig model. The aortic valve is typically projected here at 12 o'clock. As we say, there's often one large anterior leaflet. The posterior leaflet has three different scallops that we call P1, P2, P3. P2 is the most common cause for prolapse. This is in a flow bath in a pig model. showing basically the exact same analogy. And what's really interesting is if you put the camera at the LV apex and look up at the outflow tract. So there's the aortic valve all the way up there. I just want to remind you this rich, complex network of chordal structures in the subvalvular apparatus that holds the mitral valve intact during systole. It's just remarkable how the surgeons fix and cure mitral valve disease. This is what we see on three-dimensional echo. I'd like to imagine that we are mirroring what you see in both of these pictures. We get very good diagnostic information. So the pathology mechanism help guide either surgery or catheter-based intervention. This is back to Frank Netter, reminding you that to have a competent valve, you need normal leaflets, cords, Packly muscles, the ventricle, and this annulus. And when the surgeons repair the valve, and I'll show you that in a moment, the annuloplasty ring becomes important. And if it all works together, here it is when we turn on the labels. Here's your left ventricle, the anterior, the posterior leaflets, and look at the mitral valve. It doesn't close like shutters on the window. There's almost up to a centimeter of overlap to create the seal. So you can imagine as your ventricle dilates or your atria dilate, and your leaflets can't touch, you'll leak. Okay. For the classification, what's important to understand is that we need to understand whether it's primary disease, which means it's a leaflet issue, or secondary issue, it's the ventricle or the atria. And we don't spend a lot of time, but just mechanistically, I want you to understand this kind of pathology. So at one example, I hope this thing plays. Oh, it doesn't play. But anyways, there goes the arrow. There's perforation, the base of the anterior leaflet. This is perforation. We don't see this so often. This is mitral valve prolapse. Hopefully you can see this is the prolapsing P2 scallop, and all those little finger-like projections are torn cords that we see flopping into the left atrium. 2 to 3% of the population has mitral valve prolapse. A tiny subset of them have ventricular arrhythmias. Occasionally they are fatal from VT. Rare, but we should at least recognize it. So when you see the patient with prolapse, at least ask about palpitations, lightheaded, maybe syncope. Most of the time, the answer is no, but the answer is yes, it's worthy a little further investigation. This is the spectrum of mitral valve prolapse. I told you that the simplest and most common form is P2 prolapse, a simple torn cord, very easy to repair for talented surgeons who spend time in the space. But as you get more and more complex disease, you get more diffuse myxomatous changes until the very end, it's bileaflet prolapse, and this is what we call Barlow's valve from the South African cardiologist, I think from the 60s or 70s, who described this, Dr. Barlow's. This is an example of rheumatic mitral stenosis. This is a T looking up at the mitral valve. It's described as a fish mouth, not that common. Hopefully this will pay, though it's not so important if it doesn't. There it is. This is mitral annular calcification. This is the annulus that is heavily calcified and occasionally will cause mitral valve disease. If you can't see it, there it is highlighted in yellow. If you can't see that, there it is on CT. All that white is calcium. It should not be there. Occasionally, it's the mechanism for mitral regurgitation. This thing is an example of inflammatory changes, sometimes from radiation damage. It's not going to play, that you can get either from occasionally, okay, radiation, we'll leave it at that. For the secondary pathology, the most common that we see is ventricular. There it is, dilated ventricle. I hope you can appreciate here with the arrow that the leaflets are tethered. They're pulled towards the apex of the ventricles. The ventricle dilates, it pulls the Packly muscles, the chordae, and then the whole mitral valve gets tethered and these valves leak. And more recently, we've come to understand this also works when the atria get too big. Ventricular function is normal. You can see how large this left atrium from chronic long-standing atrial fibrillation as opposed to this one. The annulus dilates and the leaflets can't coapt, and you get mitral regurgitation. The natural history of severe mitral regurgitation, this is a lot. This is the typical way we think and worry about that. You have LV dysfunction, begets LV dilatation, then your ventricle dilates, you get more MR, you get increased walk stress, and around you go. And from the patient's perspective, we worry about recurrent issues of heart failure, quality of life, and increasing mortality. Left untreated, just like with aortic stenosis, onto the right side, bad, poor prognostic markers, RV dysfunction, secondary TR, and pulmonary hypertension. Our job when we see these patients, understand the natural history and figure out what their disease is, and would they do better off with surgery, medical therapy, or what is their role after they've exhausted medical therapy for edge-to-edge repair? This is a catheter mitral clip The brand name here, edge-to-edge repair with M-tier, opening up here in the left atrium about to guide the procedure. This is an example of mild mitral regurgitation. We're now talk about grading. Grading's not always so easy. I know in the report it says mild, moderate, severe, and we take it. But I just want to show you behind the scenes. This is mild. Even I got this one, right? This is severe. This is a huge amount of prolapse with an anterior leaflet. Tremendous mitral regurgitation. But sometimes these eccentric jets are difficult. And what the American College of Cardiology really reminds us is the color's just the beginning. There's all kinds of quantification. And if there's doubt on echo, TE, or MRI when there's discordant data. We're not going to go through this. I just show you the American Society of Echo reminds us or encourages us or nudges us to think about a more complex, sophisticated way of trying to figure out what is mild, what is moderate, severe. And I'll just share with you two commonly used variables, just to give you an idea if these worlds pop up in your reports. There's something called PISA. This is what it stands for, proximal isovelocity surface area. There's a little bit of formula. There's a variable that we square, which I'll share with you in a minute. But the idea is that if blood is rushing from the left ventricle into the left atrium, this kind of upside down mushroom is perhaps one way of thinking about it. We're here to measure the orifice, or this portion, the hole, if you will, as blood is rushing towards the funnel. Maybe that's a better way to say it. Here on this color map, we're here to measure this radius. With a little bit of math, we come up with a PISA, the effective regurgitant orifice. More than 40 is severe. Works very well, nice, effective. But there are limitations. It doesn't work as well for the eccentric jets. There are measurement errors because we're going to square our mistake. It doesn't work for multiple jets. It assumes a hemisphere, which doesn't work for these secondary MRs. So here's an example. If this thing plays, there we go. This is a very eccentric jet from a dilated ventricle. And you might say, I see the PISA. I see this color jet, and you would be right. The problem if we measure in this plane, we're looking in this view here, and it's accurate. But the complexity of the three-dimensional nature of the mitral valve, we turn the probe 90 degrees, we get a valve that looks like this. And if we only measure this, we will grossly underestimate the severity of mitral regurgitation. What we have now come to use is a way of further refining this, and it works well for eccentric jets and sometimes multiple jets, is that we get a transesophageal echo, and with this fancy three-dimensional multiplane reconstruction, which basically means we freeze the image. We draw a line here and says, this is our orifice, this is the hole, and we can measure and trace it. And with a little practice, we get some very accurate numbers to try and figure out how big that hole is. And you can see this is not a circle. Old data, Marie Serrano from the Mayo Clinic, there's a typo, sorry about that last N, shows that untreated primary valve disease, this is mitral regurgitation, severe MR, untreated does poorly. For the ventricular issues, right? The valves find the ventricles too big, severe, untreated. This is natural history data. They do not do well. Keep in mind that even the moderates don't do well. The most of our focus is on the severe. Surgery is the gold standard for mitral valve prolapse. You have mitral valve prolapse, send to a good surgeon. If you can repair, not replace, if you can repair, you normalize life expectancy. This is in the Medicare population, average age 74, almost 50,000 patients. That's what you want, a good surgical repair. And here's an example. As we follow patients, a 65-year-old woman walking several miles a day, feeling well, a long time ago, 3+, moderate to severe, doing well. It progresses, as it often does, and now it's severe. Severe does not mean it needs to go to surgery urgently. We can still follow these patients. Look, 5 years we followed her, a hyperdynamic ventricle. Remember, the left ventricle dilates in end diastole. We expect that. That's the volume overload nature of mitral regurgitation. At end systole, as long as that number is small, we're safe. End systolic dimension is normal. EF greater than 60%, no symptoms. All is well until she develops symptoms, atrial fibrillation, new pulmonary hypertension, and we know these things are markers for poor prognosis, time to go to surgery. Oh, I hope this thing plays. There it is. I showed you this one before. Here it is on 2D. Here it is on 3D. A lot of color. You can see the PISA goes to get surgery. If you look here in the left atrium, there's absolutely no color. A perfect repair. Those two little dots represent the annuloplasty ring seen in a side view. I want to now move from primary to secondary mitral regurgitation because this, by the way, is just more common, probably 3 to 4 times as much common. This is basically heart failure with a dilated ventricle and mitral regurgitation. The COAPT trial changed our thinking. So we're not here to talk so much about the treatment options, but it has given us insight to how to manage these patients. So a large range of EF between 20 and 50, 3 to 4 plus, that's moderate to severe or severe, had to be on really good medical therapy, fix the ventricle with CRT therapy, seen by heart failure specialists. An older crowd, a lot of heart failure, low ejection fraction, dilated hearts, relatively successful implant. And at the end of 2 years, you can see that the risk of heart failure hospitalization cut almost in half. You treat 3 patients to save 1 heart failure hospitalization. In the secondary analysis, there's a reduction in mortality. You treat 6 patients at the end of 2 years, you can reduce the number, you can reduce all-cause mortality. I would be remiss from Kansas City, the land of John Spertus, who's one of my partners and colleagues and friends, if I did not talk about Kansas City cardiomyopathy questionnaire. This is a questionnaire that we give to patients. It's patient-reported outcomes. They tell us how they feel. An impact of more than 5 percentage points is clinically significant. And you can see if you got your device on top of guideline medical therapy, if I did not emphasize this, I would be remiss. These are patients who are on maximum doses of guideline medical therapy. If they still had low EF and heart failure and significant mitral regurgitation, they got the benefit of device therapy on top of medical therapy. Right. Remember, medical therapy, guideline-directed medical therapy, the 4 pillars. SGLT2 inhibitors, ARNIs possibly, beta blockers, and spironolactone or MRAs can reduce significant mitral regurgitation in up to 50% of these patients. A lot of these patients can't tolerate maximum doses. That's okay. Try your best. Give them to what they can have. After a couple of months, if they still have symptoms, still have mitral regurgitation, you can move them on. And just to give you an idea of what this looks like, I've shown you this picture before, a dilated heart. These leaflets don't touch. This is 3-dimensional imaging of the mitral valve. That black space is not dropout. This is the gap. Huge amount of mitral regurgitation. They start off with a V wave in the left atrium of 47. No wonder they're profoundly short of breath. Down to a range of 14, they can breathe, and they're very thankful for this. This is what it looks like. We take this device, we put it in the left ventricle. The posterior leaflet goes on one side, the anterior leaflet goes on the other. We close the device with essentially no mitral regurgitation at the end. You can actually watch it as we're closing the device. I'm going to let the cine play again. So it's open, we're closing, the color goes away, the mitral regurgitation. This is how we should think about these patients. As I transition to the tricuspid valve, I just want to remind you how dynamic functional lesions can be because they vary based on the ventricle. So an example. An 85-year-old woman presents with marked hypertension, a small non-STEMI. Let's look at her baseline echo. 2-dimensional image here, the 2-chamber view, a huge amount of mitral regurgitation. She's treated, her blood pressure's treated, a little afterload reduction. A few days later, the MR has gone away. So we were fixing the hypertension, we were fixing the ventricle. Likely the mitral valve was innocent. It was this functional nature. The exact mechanism, I'm not sure, but if we make the ventricle better, we'll make the mitral regurgitation in the non-primary valve disease. This must have been some secondary mechanism, and show you the same thing for the tricuspid valve. We now, when we do edge-to-edge repair, we will prehab patients. We bring them in, diurese them 2-3 liters in a day or two for torrential tricuspid regurgitation. This is transesophageal echo. This is the right ventricle. The red arrows show you that the tricuspid valve doesn't even close when it's supposed to close. Look at that. Several centimeters of a gap. No wonder this thing leaks. There's no color, but you can imagine. A little bit of prehab. It still leaks, but now the leaflets are closing substantially more. So just to remind you, for the functional lesions, MR, TR, we work on the ventricle, the left ventricle, the right ventricle. And in the last 10 minutes, I'm going to move on to the tricuspid valve. Okay, why can we not easily detect TR? For some of the same reasons I've talked about before, but look at this. Symptoms of dyspnea, fatigue, relatively vague symptoms, swelling that includes abdominal bloating and low extremity edema, early satiety. As these patients progress, they lose weight, they're cachectic, they fill up very easily, and at times they will really have no symptoms, very subtle symptoms. The physical exam just remind you that even with severe tricuspid regurgitation, the murmur can be absent. In fact, often it is. And I'm going to show you in 2 more pictures. The answer are in the neck veins. Remember, aortic stenosis, high pressure, turbulence, high velocities, often we hear it. Tricuspid regurgitation is often a low pressure system. Low pressure, low velocity, doesn't make a lot of noise often. Here's a patient. The ventricles are normal. The atria are huge. I didn't turn the color on, but believe me, there's a lot of tricuspid regurgitation. I ask her, really no symptoms? I take my time, I do okay. This is the history, right? So do they have symptoms? Do they not have symptoms? I'm not here to say I have the answer. I'm just telling you it gets subtle and nuanced in the older patients when they say, I am fine, leave me alone. And maybe we should. Here's a patient with severe tricuspid regurgitation. In fact, here you can see how severe is not an adequate description. It's massive, if not torrential tricuspid regurgitation, an inpatient I took care of. And believe me, no murmur, no murmur. Can you believe that? But the TR we see, this is what it looks like, a different patient. Here's a patient, neck veins that bulge. This is the sign of tricuspid regurgitation. We should look at the neck veins. May not hear the murmur. Another patient of mine, torrential tricuspid regurgitation. There's his neck veins. And if you actually look above the arrow, it actually goes all the way up to the angle of the jaw. And this gentleman had skinny feet. So we diuresed him, got rid of his edema, and still has bulging neck veins. This is the marker for tricuspid regurgitation. Echo. Sometimes it's humbling. Here's a small little jet. I'm pointing to it. It's a small little jet. You're pretty underwhelmed, so am I. But remember the mitral. It's a complex structure. We turn the probe 90 degrees. It's a very broad band. So sometimes on transthoracic echo, we might miss it if we don't look carefully and carefully enough. And here's an example. This is now looking right down at the blue plane, and it's a slit. So one view looks tiny, the other view looks broad. And here it is on 3-dimensional imaging. You can actually see the hole is actually much larger. We just haven't captured it all. That black dropout is the regurgitant orifice. Like the mitral, the tricuspid valve is a complex saddle-shaped structure. Here's the tricuspid. Here's the kind of backstory to tricuspid regurgitation. For the most part, it's clinically silent. It's often present for years before patients would develop signs and symptoms. And over time, the right ventricle may enlarge and develop dysfunction even before we can recognize the tricuspid regurgitation. Historically, people have given talks that the TR was the forgotten lesion, the forgotten valve. Now it's front and center. It turns out tricuspid regurgitation is remarkably common in the heart failure patient. An older study, European study in 2017, suggested moderate to severe or more was 20% across the entire spectrum of the heart failure phenotypes. A more recent study looked at that 13,000 patients of prevalence, somewhere between a third and half, depending on the status of the ventricle. Common. And TR is associated with a high mortality. But to date, clinical trials have shown a consistency of excess mortality in patients with heart failure, and we should think of it through this lens. We can improve quality of life, we can improve the symptoms, but for the moment, the data say we improve quality of life with intervention. Maybe just to drive home this point one more time, an old study from Marie Serrano from the Mayo Clinic looked at 11,000 patients, some heart failure under EFs of under 50, and you can see the graded response that the mortality or the survival gets worse depending on the severity of tricuspid regurgitation, independent of a lot of other risk factors that we would think would impact mortality. If you're interested in this topic, a very nice overview here published just a couple of months ago. One concluding comment: we have no specific disease-modifying medical therapy for the treatment of TR, though we could make it better. Think about the left side, and I'm going to walk you through here. I've told you that here before. So, unlike aortic stenosis, that is clearly a progressive lesion, or primary mitral valve disease, which is often a progressive lesion, such is not the case with tricuspid regurgitation. One side is mild, the other side is severe. But this study here shows us and reminds us, this was a study with almost 1,000 patients with more than moderate TR followed over 2 years, and asked the questions, what would happen to the tricuspid regurgitation? Only 19% of the patients actually got worse. 40% stayed the same. And look at this, over a third got better. So this is not a scenario where you have to follow these patients with serial echoes, because the majority of the time it's going to be stable or get better. You can follow symptoms in neck veins, symptoms of exertional dyspnea, and fatigue. Okay, let's talk about classification as we wrap up tricuspid regurgitation. You can see the vast majority is functional secondary. It's not a leaflet disease. It's either from the atrium or the ventricle. And this is what it looks like. Your atria dilate, either from HFpEF, which is becoming more common, which is why this is so common in older women, because they are more likely to have HFpEF and long-standing atrial fibrillation. Your atria dilate, your leaflets can't co-up, and it looks like this. And you'll see a picture, there it is. She was 100, let me tell you, severe tricuspid regurgitation from HFpEF. The other sign is the ventricle dilates. And as the ventricle dilates, the leaflets get tethered. Remember, the leaflets are also subtended or connected to the papillary muscles, the chordal structure. The ventricle dilates, the leaflets go for the ride. Here's an example of tethered leaflets. Hopefully you can appreciate that. Here is severe mitral regurgitation. Look at the right side. Oops. Let me make that play again. Leaflets don't even touch. I don't have the courage to turn on the color. So an example that you get tricuspid regurgitation either from HFpEF, long-standing atrial fibrillation, or left-sided disease, they're either LV dysfunction or valvular disease. Yes, you can get it from implantable pacemakers or defibrillators. And the only reason why this is my editorial about whether it's heart failure, so is the lead the cause of the disease of tricuspid regurgitation, or is the lead the marker of left-sided disease from atrial fibrillation, tachycardia syndrome, and low EF? But if the lead's involved, it can cause fibrosis, it can cause problems in the subvalvular apparatus, it can impede leaflet closure, occasionally it can perforate the lead. This was a picture I got here from Jack Imaging. Yes, you can try and surgically remove it, you can laser lead extract it. It doesn't really work. The fibrosis has occurred, the valves still leak. This is not how we typically think about managing these patients. And occasionally, though not often, though occasionally we will get primary valve disease where this is prolapse. Okay, just a word just to kind of expand upon the pathophysiology of tricuspid regurgitation, particularly when it's advanced. And if you're interested in RV failure, this is a great review by Ryan Tedford in the New England Journal. But most of these data came from Becky Hahn from these two papers. As the right ventricle dilates from the volume overload of the right of tricuspid regurgitation, the septum gets pushed that way towards the left ventricle, and things don't work well when your septum gets flattened. You impair diastolic function. You can't fill the ventricle if it's getting squeezed by this ventricular septum. It turns out if your left ventricle works well, about 30% of ventricular function on the right side comes from the left ventricle. This idea of ventricular interdependence, or that the right ventricle is attached here, and as the ventricle not only, let me show it here, not only, squeezes, but torques. It has this radial and circumferential contraction. It pulls the right ventricle along. So if you're flattening the septum, impeding diastolic function, impeding systolic function, your right ventricle will work less well. As you get more RV dysfunction, you get more fluid congestion, edema, you get hepatic dysfunction, renal dysfunction, you gain more fluid, you get volume overload, you get LV dysfunction, and round and round. And if these problems are not present at rest, likely they can become more apparent with exertional dyspnea. So these patients may be relatively well at rest, but their symptoms are fatigue and tiredness. It's not just because the blood's going backwards and you can't preload the left ventricle, that's part of it. It's these mechanics. So if I would now here to summarize and kind of encapsulate some of the themes we talked about valvular heart disease, I would say the following. It's common. The prevalence is clearly increasing with our aging population. I might even add, as we allow patients to live longer and better, as we treat their heart failure and their coronary disease with devices, we're seeing more valve disease. It's associated with a high morbidity and mortality. There are challenges in making the diagnosis from the physical exam. I've showed you that. The history is often challenging. Patients often live within the confines of their symptoms. Very common. I'm fine. The next sentence you got to ask is, please, I'm fine in the setting of doing what? So they may say, I'm fine, I'm doing everything I want to do, but they're not doing much because they have symptoms. Or the example I've shown you with the treadmill, they don't recognize their symptoms. And after the ejection and valve severity, if you're looking at the echo, there are lots of other markers. We've just touched upon them about stroke volume, about the status of the ventricle. Is it hypertrophy? Is it dilated? What's the status of the right ventricle? Do they have multi-valve disease? Do they have pulmonary hypertension? And though this was not really to talk about therapies, I did allude to them. We do have really good therapies. Medical therapy is the cornerstone, revascularization, CRT therapy, transcatheter intervention. So this has completely changed the landscape. People call them game changing because we can treat so many patients. And surgery, still an integral part for how we manage patients with valvular heart disease. And with that, top of the hour at 1 o'clock. Thank you. And I'll hang out for questions if we have time, Kaylee.
Sure. I do not see anything in the Q&A right now. So we can close out. Thank you so much, Dr. Skolnick, for sharing your enthusiasm, imagery, expertise, everything. And thank you for all the participants for registering and joining today. You will get an email with the link to claim your continuing education credits. If you should have any difficulties, there's also an AHA contact on there. Feel free to email. And this concludes our second webinar in the series of 3. Make sure and join for the last in the series on July 29th. Thank
All
you
right.
so much.
Thanks.